Can all right. So I'm Ben. I'm a PGY3 second year resident at LSU. Title of my grand rounds presentation is PubMed is your friend. This grand rounds is generously reviewed by Dr. Sahu. So this is our target audience, everyone interested in ophthalmology and patient care. We are accredited by the LSU university system. Disclosures, I have no disclosures, and my co-presenter, Josh Peng, who's sponsoring a medical student, has no disclosures. So yeah, at the end, there's a survey that Josh will send out required for must be filled out to get credit. So our story here is we have a 52-year-old Caucasian female, and her complaints, she had a lot of complaints, but these were a few. She said she had pressure in both eyes, swelling right below the eyebrows, and then she's complaining of mucus discharge, discomfort with contact lenses in both eyes. And history-wise, she had nasal reconstruction. She was a former boxer and had ocular chemical injury years ago. Her eye vitals, vision pressure, pupils, motility, all normal. So on an exam, the external exam, you notice in the right lacrimal gland area, along the left lacrimal gland area, there was some enlargement, some swelling. And in the red, you'll see in the left, in the lid, lashes of the right side, localized swelling measuring 1 centimeter in diameter from the superior temporal aspect of the orbital rim. And then in the conjunctiva, you'll see that there was a lacrimal gland cystic lesion measuring 5 millimeters in diameter. And you see some of that on the left side, but it's most prominent on the right side. The rest of the exam was normal. The dilated eye exam was normal. These are the external photos. So the leftmost photo is a photo of the external photo of the right eye. Just looks pretty normal up front. You notice she's wearing a contact lens. If you look at the photo on the right, that's the temporal side of the right eye. You notice there's somewhat of a bump, a contour there. But you'll see it right there, right on the temporal upper eyelid. And when you, raise the eyebrow or the eyelid, you'll notice that there's a cystic lesion poking out of there. It looks thin, but it's definitely extremely large. There's some disorganization. Just based on that story, based on this photo, what are your differential diagnoses? Very good. Lacrimal gland lymphoma will be excellent. Anyone else?
Pleomorphic adenoma.
Yes. Another excellent suggestion, Zach.
Dacryops.
Dacryops. Oh, wow. That's amazing. All right. Well, Dacryops happens to be our diagnosis. So these are just a sample of the possibilities, diagnoses. Dacryops being what this is. And most of this story is, this presentation is actually just talking about Dacryops and also the surgical management of Dacryops. Dacryops is actually fairly it's not necessarily rare, but it's poorly documented. And if you search on PubMed, there are only 70 results. And then so Dacryops, other names, is basically a lacrimal gland cyst. And second line, you see Dacryops is a benign epithelial tumor of the lacrimal tissue that represents ectasia of the lacrimal gland ductules. And any lacrimal tissue tissue, including the accessory lacrimal glands and even ectopic lacrimal gland tissue. The dacryops can sort of happen anywhere within the on the conj in the eye. The clinical classifications, there are 4 different areas where dacryops can appear. The palpebral lobe one is what they call simple dacryops. This is what our patient has. It's the most common. And then you can have one that's orbital. You call that orbital dacryops. And then you have the cysts of the accessory lacrimal glands of Cross and Wolfram. Is conj within the fornix, or the conj further out towards the lashes, the palpebral conj. And then you have ectopic cysts, just lacrimal gland tissue in different places. Yeah, generally it's asymptomatic. So dacryops is asymptomatic, has varied symptoms, depends on type, size, and associated complication. Another thing noted is that sometimes like it just changes in size over time. Sometimes it gets larger, sometimes it gets smaller. If you leave it alone, sometimes it goes away entirely, or sometimes it just causes a lot of pain. It's highly variable because it changes in size and it depends on where it is. And so yeah, so it's rare in the sense that it may be present, but it may not be clinically significant. There may not be causing any symptoms at all. So yeah, there's limited information on it, even in oculoplastics textbook. And then the estimates of the estimated incidences are for the orbital dacryops range from 0.5 to 2% of the population, and the incidence for the lacrimal gland dacryops, simple dacryops, the one that our patient has, ranges from 1 to 17%. So the pathogenesis, the idiopathogenesis, it's unclear. They basically no one. It's more or less idiopathic. They don't have any clear-cut inciting factor, but definitely anything that involves damage to conj surface, previous trauma, etc., increase the risk for developing dacryops. Yeah, so trauma, chemical injury, chronic conjunctival inflammation, and ocular trachoma infection. Yeah. So in terms of diagnosis, the interesting about that, well, when you diagnose it, you simply just look at the photo, or you simply look at the gland, and you'll notice that it's mobile, non-tender, fluctuant, small, or not, and then it looks thin. It's a very thin membrane, and the only way you can confirm is by basically resecting it and then having a pathologist confirm. Here, while it's a benign lesion, it has been reported to cause proptosis, strabismus, superimposed infection, and hemorrhage. So on histopathology, dacryops is a closed ductal cyst arising from lacrimal gland tissue. Main characterizing features. Are you guys able to see my mouse? Okay, great. So if you read it out loud, so non-keratinizing epithelial cyst is composed of a double layer of columnar cuboidal epithelial cells right over here, surrounded by the fibrous wall and associated lobules of the lacrimal gland parenchyma. And so management, the supportive management will be to avoid anything that patient notices makes that large or increases symptoms. Some of which include cold weather, wind exposure, to avoid those, or just to do just to give topical lubrication. And then the definitive management is surgery, complete excision being preferred. And if it's a deep in the orbit, you're going to have to approach it from the orbital, or go into the orbit to take it out. You can't go from a conjunctival approach. Marsupialization is an alternative. Though it's less invasive and it preserves lacrimal tissue, it has a higher risk of recurrence simply because you do not remove the entire lumen, the cyst wall entirely. The surgical complication, it's the same with anytime you access the conge near the lacrimal ductals, is that you can cause tear deficiency, and of course you can cause recurrence and fistula formation. So back to our patient. So Dr. Sahu, he hasn't taken, I don't think he told me he hasn't had much experience simply or with dacryopes clinically and even surgically. So he consulted PubMed to see if there was any easy way to go about taking the dacryopes. So he found this paper published in the Aesopers Journal. So it's basically these people, they use fibrinogen, thrombin, and methylene blue, and then they inject it into the dacryopes to basically outline the cyst and to take out the cyst in one total piece and block. And then the Lure-Lock adapter is important, and I will explain it in the following images. And also the 24 gauge shielded intravenous catheter is also important, and that will be explained in the following slide. So one thing to point out is the 24 gauge, so the Lure-Lock, like 24 gauge shielded IV catheter. So this one actually, this 24 gauge shielded IV catheter actually has like a plastic tube that sits over the actual needle. So in the lumen of this plastic tube, you have the actual needle. So basically on surgery, so these are pictures from the paper, but they are almost representative of what happened in the OR with me and Dr. Sahu. So in picture A, basically what we did was we, with the 24 gauge catheter needle, we basically poke or we enter the cyst and we allow some drainage of the cyst fluid. And then on the tip of that catheter, you have the you have the Lure-Lock adapter, and then you keeping the catheter within the cyst lumen. You take your syringe full of fibrinogen and you squirt it onto the needle. The needle, you inject the fibrinogen there. After you've gotten some fill of the cavity with fibrinogen, you unscrew the needle or the syringe, and then you come back in with your other syringe full of a mixture of methylene blue and thrombin. And then you slowly inject, and once you've inject, you get a nice solid outline of the cyst wall, and then it allows you to bluntly dissect around the cyst without actually breaking the cyst wall, and eventually you completely bluntly dissect around it, and then you're able to extract the entire cyst with the entire cyst wall intact, with minimal damage, minimal collateral damage to the tissue surrounding the cyst. And this is what it looked like in the paper. One thing that happened differently for us is that when I went in with the 24 gauge catheter, once I entered the cyst, it essentially collapsed because all the fluid just drained out really quickly. So Dr. Sahu had to take over, and he fiddled around, and then eventually he filled what he believed to be the cyst itself. He refilled it, and then we injected the fibrinogen followed by the thrombin, same with blue, but also when we removed it, we didn't remove it in one piece. We removed it in a piecemeal fashion. That's just architecture of the cyst itself. And so we had I think 3 or 4 pieces No, this is an actual. This is not the actual patient. This is the pictures from the paper that we drew inspiration on for this pioneering surgical method. Yeah. So this is a before and after. So on the left is the before picture where you see the bump, the swelling on the temporal side of the right upper lid, and then 1.5 months after surgery, you can see that there's no longer that swelling overlying the lacrimal gland. And that is my presentation. These are my references. Yes, we are open for questions and comments.
How many patients did they operate on in your paper?
They operated on one patient in their paper. I'm certain that a lot of things went wrong, or things did not go entirely according to plan, but then they publish it in such a way that it went. Okay.
Did they mention possible complications of that technique in the paper?
No, they did not mention any possible complications of the technique. And the beauty of it is that the thrombin, the thrombin, the fibrinogen, there's a sort of they can be absorbed by the body if there's any issues. And even if you sort of inject it into beyond the space of the cyst, it's just going to get resorbed. It's not going to create like a nidus or infection or anything, or erosion. Yeah.
Has anyone else published any similar techniques?
No, no one published it. But Dr. Sahu, he consulted PubMed, and that's what he found. And that is why this paper title is "PubMed is Your Friend." All right.
Hey, Ben, Zach, I have a question. So essentially with Dacrops, I'm just trying to get the takeaways here. So can you, do they have this, if you're pretty convinced based on the clinical appearance of this and it's not symptomatic, is it okay to watch it, or is this something that you have to biopsy because you can't really tell what it is other than just like an enlarged like lacrimal gland?
Yeah, actually, Zach, that's actually a really good question. So there's more on the story. For this patient, she presented to Dr. Sahu with this, with the Dacrops. Actually, she had it on both sides. We didn't have pictures we don't have pictures that far back, but she had it in both sides, the right greater than the left. And then, they were much larger on documentation prior, and they were more irritating to the patient. And Dr. Sahu says this is likely Dacrops, but I will not. But Dr. Sahu didn't proceed to operate, even though it's irritating the patient because she had a lot of other things going on. But at the end of the day, if it's bothering the patient and you think it's Dacrops, you can utilize this method. You can take it out, and then you can confirm that it is Dacrops on histology. If for some reason it happens to be something else, that is still okay because you resected it and you in a controlled fashion. The beauty of the fibrin and the thrombin mixture is that it gives you a space where it's a controlled space to take tissue out.
One thing that I learned the other day with a patient that had the same thing is that a way to tell like a solid lesion from a Dacrops lesion is to use the muscle light and try to transilluminate. So if it transilluminates, it's most likely Dacrops versus a solid lesion which would not transilluminate.
Yeah, and I guess like just to follow up with that. So my question is like, so you transilluminate it. You're pretty sure it's Dacrops. Do you need to biopsy it or remove it just for diagnostic purposes to rule out other possible etiologies, or is this something that if it transilluminates that we can watch and follow and treat if it's symptomatic essentially?
Yeah. So basically, you can if you think it's Dacrops, you can leave it. If it's bothering a patient, you can take it out. If you are not sure, but you think there's a high chance it might be Dacrops, you can still utilize this technique, and then you can still take it out, and you can still send it to pathology just for confirmation. But this is a clinical diagnosis up until pathology gets involved. Yeah.
Thank you.
All right. Okay. Excellent. Excellent. Okay. All right. Thank you all. Good seeing y'all.
Can you guys see this?
Yep, we can see it.
Okay. Just making sure. Okay, so my name is Hayley Redrick. I'm one of the LSU fourth year medical students. For those of you who haven't met me, I'm finishing up my 3rd month with you guys. And this is my Graham Rounds presentation. Thank you to Josh and Dr. Barron for helping me with this. Okay, so I'm not gonna go through this. All right, so this was our 30-year-old African-American male with a past medical history of developmental delay, hearing loss, and type 2 diabetes. He's not on insulin, last A1C was 8. He was referred to general clinic by optometry for glaucoma evaluation. So in optometry's note, they said that he was having blue sclera and hyperpigmented iris in around the left eye. His IOP was 18 and 20. Cup to disc was 0.65 in the right eye, 0.6 in the left, with a very thin temporal rim. His past ocular history, so he's never worn glasses or contacts, no history of trauma to the eyes, no surgery, injection, or lasers. Family history, so he denies glaucoma, macular degeneration, or other blinding ocular diseases. And past medical history we already discussed, and then no allergies. So base exam, his visual acuity was 20/20, 20/25. Confrontational visual fields, they appear full, but he was a difficult patient to assess because of his developmental delay. Extraocular movements were full in ortho, both eyes, pupils 3 to 2, round wrist, no RAPD. Tone of pin pressure was 20/21. We didn't applanate him because of his developmental delay and him being kind of a difficult patient. Pachymetry was 639, 647. So external exam, the right eye was normal. The left eye, he did have the increased pigmentation of the skin of the left cheek. Slit lamp exam, lids and lashes were normal, both eyes. The conjugal sclera of the right eye, white and quiet, but the left eye had bluish discoloration of the sclera inferiorly. Cornea, the right eye, there was a linear anterior stromal scar, but the left eye was clear. AC was deep and quiet. Iris, both eyes were round and reactive with no MBI, but the left eye was diffusely hyperpigmented. The lens was clear, both eyes, and vitreous was normal. All right, so these are some external photos. I'm not sure if you guys want to, I mean, I basically already said kind of what we're seeing. But we're seeing the right here, the bluish pigment that we were talking about in the conj, and then this is an external photo showing the hyperpigmentation of his left eye and cheek. Fundus exam, nerves were normal, cup to disc was 0.6 and 0.8, and that was similar to what optometry note said. Disc, macula, and vessels were in periphery was normal in both eyes. Okay, so our differential diagnosis, so if you just kind of think we had this glaucoma suspect, and then he also had blue sclera and hyperpigmentation. This differential is kind of more focused on blue sclera, but what kind of picture does that paint?
Osteogenesis imperfecta.
Osteogenesis imperfecta.
I also think nevus of Oda or sclera malacia and perforans for blue sclera or for uvea.
Okay, so very good. So that's kind of what we were thinking. So osteogenesis, I didn't want to give it away earlier, but and but he denied breaking bones. And so that was kind of out of the picture. Ehlers-Danlos was also something that can cause blue sclera, and he didn't have that picture. What he actually had was nevus of Oda, which somebody mentioned. And so that's also called congenital ocular melanocytosis. You can also see the blue sclera with certain drugs. So he was asked about medications that he takes. And like you guys were saying, sclerocoroidal calcification, sclerohyalin plaques, and senile scleromalacia, high myopia, and scleritis are all causes of this. So what kind of testing did we get on him? So for his glaucoma evaluation, we got an OCT, which you can see that the right eye, he had some thinning temporally, but when you look at this left eye OCT, it's just very unreliable. So it was pretty hard for him to take some of these tests. And then same with visual fields. You can see he had like numerous fixation losses, 10 out of 11 and 7 out of 11. And the note patient kept looking around. So we don't really have the best testing for him right now. But our plan was for him to return to clinic in 6 months for gonio, IOP check, and repeat OCT, RNFL, and we're going to monitor him off drops for now. But what I want to talk about a little bit is nevus of Oda. Even though it's not that high yield, it does come up sometimes. So we're going to just talk about it a little bit. So this is a benign melanosis involving the distributions of the first and second trigeminal nerve. There's an entrapment of melanocytes leading to gray-blue hyperpigmentation. It's usually unilateral, but it can be bilateral in 5 to 10% of cases. And although its clinical characteristics are well defined, and we'll talk about that, the epidemiology and pathogenesis are not as clear. So inheritance, it's currently thought to be non-hereditary. It generally presents within the first year of life with a second peak around puberty. Epidemiology has a female to male ratio of 5 to 1. And because of this, it's thought to have a hormonal mechanism of pigment development, but this hasn't been studied. It's more common in people of Asian and African descent, and the incidence rate in Japanese populations has been reported to be 0.4%. And it wasn't really studied in other populations, but I would imagine like it's much lower around here because it's more common in Asian populations. So who is Oda? So this disease was actually first described by Masayo Oda, pen name Monkyotaro Kinoshita, in 1939. He named this condition nevus fusco-ceruleus ophthalmomaxillaris. His original article, you can see the title there, The Nevus Fusco-Ceruleus Ophthalmomaxillaris and Its Relationship to Pigmentary Changes in the Eye. He described nevus of Oda as a birthmark primarily found in Mongolian people. I looked for the original article, but no luck with that. But basically, he also talked about Mongolian spots in this article as well and related the two. Oda was a dermatologist. He was known for his research with Malassezia furfur and leprosy. And this is just a fun fact, he actually opposed the prevalent practice in Japan of segregating leprosy patients into sanatoriums. All right, so clinical presentation, we see patches of episcleral pigmentation that appear slate gray through the normal conjunctiva and are immobile and usually unilateral. 10% of people will develop secondary glaucoma in the affected eye, and the lifetime risk of uveal melanoma in these patients is 1 in 400. And although nevus of Oda isn't as common in people with fair complexion, they are more at risk of developing uveal melanoma. So because of that, we want to do yearly screening for glaucoma and malignant uveal melanoma by an ophthalmologist and follow them probably with a dermatologist as well, because melanoma can develop in any site that melanocytes proliferate. So I read a little bit about the cutaneous melanomas. So they're actually more difficult to diagnose in these patients because they don't display the classic A, B, C, D, E changes in melanoma. So if you remember from med school, the asymmetry, borders, colors, diameter, and evolution. So here they actually present as nodules within the hyperpigmented region that oftentimes don't have any overlying changes. And it's very rare, so there are only a dozen published cases of cutaneous melanoma from nevus of Oda, but it's still something to look out for. Within the eye, melanoma progressing from nevus of Oda most commonly presents retroorbital or within the choroid. But just interesting is that there actually has been a reported case of scleral melanoma from the hyperpigmented region there. So these are just other findings that have been reported in different case reports of people with nevus of Oda. So buccal involvement has also been reported. So this also has potential for malignant change. So we have to monitor that as well. There was an atypical giant cellular blue nevus on a nevus of Oda, which is shown in this picture right here. This is an uncommon benign variant of blue nevi characterized by rich cellularity and an abundance of melanin pigment. There's also been 10 reported cases of meningeal melanomas associated with nevus of Oda. And I thought this was interesting. There was also a case of pruritic nevus of Oda. And they, in the report, they said that they think the pruritus might be explained by the increased quantity of mast cells observed in the lesion, or the neuronal stimulation of the ophthalmic and maxillary divisions of cranial nerve 5. Okay, so nevus of Oda associated glaucoma. This can cause secondary open-angle glaucoma in 10% of cases. The pathophysiology is thought to be due to invasion of melanocytes into the angle, which blocks drainage of aqueous, leading to elevated IOPs. Clinical presentation, so on gonio, you might see hyperpigmentation of the angle structures, and fundus exam might demonstrate asymmetric hyperpigmentation of choroidal vasculature and optic nerve cupping. So in this case study, they just discussed the pathophysiology, what it's thought to be. So like I said, generally believed to be open angle arising from direct infiltration of the trabecular meshwork by accumulated melanocytes. Okay, so we're going to talk a little bit more about secondary glaucoma because that is, nevus of Oda, you can only talk about it so much. So I want to give you guys some more high yield things. So first, let's break it down into opening to primary and secondary, and then we're going to talk more about secondary open angle since that's what nevus of Oda is. So you guys know it's primary when there's no identifiable or underlying anatomic cause, and it's secondary when an abnormality can be identified that causes the glaucoma. So you can see it's broken down into open angle, angle closure with and without pupillary block, or glaucoma that's associated with acquired or systemic disorders. So open angle secondary glaucoma has a couple different mechanisms that we could see. So one of them, increased resistance to trabecular meshwork outflow. This is seen in pigmentary, phacolytic, steroid-induced pseudoexfoliation, angle recession, and uveitic glaucoma. But another mechanism is elevated episcleral venous pressures, which is seen in carotid cavernous sinus fistula, Sturge-Weber, and superior vena cava syndrome. And then also, it can be associated with acquired disorders, so inflammation, trauma, or systemic disorders like Marfan's or Down syndrome. So the highlighted ones, since these are forms of secondary open-angle glaucoma, as well as nevus of Oda, I'm just going to touch on some high yield points of these. So pigment dispersion, pathophys is release of pigment granules from the iris with deposition throughout the AC and the angle. Clinical presentation, you see the Krukenberg spindle, which is when pigment deposits on the corneal epithelium in a vertical spindle pattern. And then you also see mid-peripheral iris transillumination defects in a spoke-like pattern. When the eye is dilated, you could see deposits of pigments on the zonular fibers and in the equatorial region of the lens capsule, which is known as shy stripe. So the classic history to look out for, 30-year-old myopic male that might be having episodes of halos or blurry vision. Look for possibly after exercise, because sometimes that's thought to maybe kick up the pigment. So look for that. 15% of individuals with pigment dispersion syndrome progress to glaucoma or elevated IOP that requires treatment, and these patients respond well to SLT. Pseudoexfoliation syndrome, so this is due to deposition of fibrillar extracellular material in the anterior segment of the eye and the angle, thought to be associated with mutations in the LOXL1 gene. Clinical presentation here, you can see deposition of fibrillar deposits in a bullseye pattern on the anterior lens capsule, you can see here. And then this is a systemic disease, so these deposits can also be found in the skin, heart, lungs, liver, and kidneys, among other places. On gonio, you might see heavily pigmented trabecular meshwork. And then you have to look out for complications with cataract surgery because of the weakened zonular fibers and synechiae between the iris and peripheral lens capsule. So risk of progression to glaucoma can be as high as 40% in these individuals, and SLT can also be very effective in these patients. Bacolytic glaucoma, so this occurs from leakage of lens protein through an intact capsule of a mature, hypermature cataract, which subsequently obstructs the trabecular meshwork. Look for an older individual with a history of poor vision, sudden onset of pain, conjunctival hyperemia, worsening of vision, and markedly elevated IOP. On slit lamp exam, look for microcystic corneal edema, plus or minus cell flare, so you might see that. Might lead to a pseudohypopium from the cellular debris. Treatment here, ocular hypotensive medications for immediate relief, but definitive therapy requires cataract extraction. Angle recession glaucoma, just a little bit about this. Pathophysiology, it's associated with ocular trauma. So what happens is blunt trauma forces the aqueous humor laterally and posteriorly against the iris and the angles, which exerts traction on the iris root, leading to a tear between the muscles of the ciliary body. And the long-term scarring and fibrosis of the trabecular meshwork can lead to elevated pressures down the road. So you want to think about this in patients 10 to 20 years following the initial trauma. And on gonio, think about looking for widening of the ciliary body band. All right, our last disorder is Sturge-Weber syndrome. So this is a congenital sporadic phakomatosis that where glaucoma develops ipsilaterally to the facial hemangioma in 30% of cases. Develops prior to the age of 2 in 60% of the cases. And then the pathogenesis of the glaucoma, it just depends on when the glaucoma presents. So when it's present at birth, it's due to a malformation of the anterior chamber angle, and patients manifest signs of congenital glaucoma. But when the patient is older than 10, this is usually secondary to elevated episcleral venous pressures. These are my resources, and any questions?
Do you know if there is any utilization of like using an ultrasound biomicroscopy to screen for like ciliary body tumors in the nevus of Oda patients, or they just look for more choroidal melanoma specifically?
Usually, I've just read about the choroidal melanomas, but I don't know if somebody else knows the answer. You guys might know more. All right. Well, if nobody has any questions, I'm going to stop sharing.
That was a great presentation. And once again, you want to look at the patient as a whole when you go into the room. I mean, if you just look at this guy at the slit lamp, you're totally going to miss his pigmented skin around his eyelids. So it's important to, use the room lights and assess the patient as a whole, not just jump to the slit lamp, because if you do, you're going to miss some of these findings.
Thank you, Dr. Barron.